Matters. My name is Cindy Gray and I'm your host. I'm here today with Colleen O'Connell Fix, and she's with Botsford Hospital, and a physical therapist, occupational therapist, pardon me. And then we also have with us again is Ms. Debbie Clark. She's also with Botsford, a physician liaison for their physical medicine and rehabilitation programs.
Yes.
Welcome, ladies.
Thank you.
Yeah.
Appreciate the invite.
You're welcome. Now, we had one of your colleagues here before, and she was talking about, and her name was Helene Rose.
Yes.
She was talking about voice therapy. That was her specialty. Yours is more occupational therapy.
Yes.
Now, I get confused between what is occupational therapy versus physical therapy. Can you tell me briefly about that?
They're two different specialties. Occupational therapy, we mainly work with the upper body. We also work with getting people back into their activities of daily living. In school, we're also schooled in the psychiatric portion along with the physical disabilities portion of the different diseases or illnesses that people have.
Okay.
So we're just working on getting the person back independent with everything they do in their daily activities, whether it's strengthening or range of motion or compensating for different things that they have to do, or teaching them easier ways to get dressed, or ergonomics. It's a lot of different.
Okay. I know a long time ago I fell when I was going up a flight of steps, and I caught myself, but I landed on this shoulder, and I ended up having to have some physical therapy there at Botsford, at the Redford facility, by the way. And being a yoga teacher, I thought, all right, I suppose if I have to, I'll do it. I learned so much from that experience. Wonderful young lady there, I forget her name, and I went for several weeks, several sessions. We used that ball, and I was pressing the ball and different things, and it helped. It helped heal a lot of the, I guess it would be the rotator cuff muscles. I think there's 4 muscles that encompass the cap on the shoulder cap, and it really helped. And I had a whole new appreciation for that sort of therapy. Now, your therapy, if someone came to you, would it be like if they've had a stroke or if they've had...
It could be many different diagnoses. They break their wrist, they have a stroke, they have arthritis, multiple sclerosis, Parkinson's, lymphedema, a lot of, we treat the whole spectrum, children through adulthood.
And what would be some examples of what you could help them, like for instance, maybe they don't use their major hand anymore, they have to use the opposite hand? Is that something you would help them with?
Well, we would try to get them to rehabilitate, like if they injured their hand, rehabilitate that hand so that they could use it functionally and independently with their activities of daily living.
Okay.
If it was their hand.
Now what about like stairs, maneuvering stairs, climbing stairs?
Occasionally we might do stairs if they required, or maybe they had to work on being able to carry their laundry up the stairs, or trying to brainstorm with them different ways to maintain their independence.
All right. And then also you have the same, or not the same, but a similar version of the LSTV, but it's the LSTV.
LSVT.
LSVT Big. The other person, Helene Rose, was LSVT Loud, which was the speech emphasis primarily. Yours is the physical, hence the word big.
Correct.
Now, in that case, you would be helping people to walk more.
It's getting the person to be able to use bigger movements throughout their daily activities, including walking, and having a long-term carryover. So it would carry over, those big movements would carry over to everything they do in their daily activities, whether it's reaching for a door or getting in and out of the car, getting dressed. Everything they do needs to be done bigger with the Parkinson's diagnosis because their movements get smaller. Their steps get smaller.
And then Helene was talking about the voice cords changing, so the movements are changing, and they're coming almost closer to the body. So you're teaching them almost an outreach, literally.
Right. They it's more of like a sensory motor problem. Where they think they're still walking the same way they always did, but they're not. And so we're teaching them that they might think that walking and swinging their arms and taking bigger steps, they'll say, this is too big, this is not what I'm used to.
Or doesn't feel comfortable.
It doesn't
for
feel
some reason.
comfortable to them,
Okay.
but it looks normal. If somebody was watching them walk down the hall, they would think like, oh, they're just walking down the hall.
Okay.
So, so we're trying to teach them that these bigger movements that they think are too big are not, they're within normal limits. This is how you should be moving. So it's very repetitive in nature, the exercises that we have them do, so that by doing them over and over again, and by adding the sensory components where we do a lot of like stomping the foot or slapping the leg when they return.
Real excessive.
Yeah, and there's a big effort with the exercises. I always ask them, what is your effort level, 0 to 10? And if they say 5, okay, I want a 7 effort. I want more effort. Aim for a 10. Bigger reach, bigger step. So they are supposed to give like 100% effort with every exercise every time.
Okay.
Which is a little different than, you know, another diagnosis. You might say, oh, are you tired? Do you need a break? We just say, take a breath and let's do it again.
And do you incorporate breathing too in what they're doing?
You do. I mean, you want to make sure that they're breathing properly. But the big emphasis is like in the course that I went to, the certification course, they said there's no junk minutes in this therapy. There's no where you're just sitting and taking a break and talking about your day. You're moving and you're exercising that whole 60 minutes that you're there.
Everything
therapy.
has a purpose.
Yeah,
geared
everything
toward the
has
goal.
purpose. Yeah.
Okay.
So they're tired when they're done, which is good.
Okay.
That's what we want.
So if you're trying to get them to emphasize movements into a larger mobility, if you will, is it their movements have shrunk in and they're thinking they're still normal?
Yes.
I never knew that. That's fascinating. Now, what about balance? Do you work with their balance too?
Each time that they come for therapy, it's a very structured program. It's an evidence-based program, so it's very structured. So they have a series of exercises that they do initially with me modeling the exercise so they can see what they're supposed to do, and with me giving them direction on how they're supposed to do the exercise, which is usually I want a bigger hand, bigger leg. Everything is big, 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 big. Because if you say I want you to reach your arm up higher and extend it out this way, it gets jumbled in their brain. So if you say big arm and show them what you want them to do, then they understand that better. And it's easier for them to follow those commands and just to make their movements bigger by seeing what they're supposed to be doing. So they have a series of exercises they have to do that involve balance and standing and sit to stand. They also have a functional component of exercises that they do each treatment session. So we go over with them, what are some things that you're having a hard time with. Like I had a person that was having a hard time putting his coat on, so that was something that we did every time, 5 times, putting the coat on using big movements. And then in the other part of the therapy is big walking. So then we're going to do a certain number of minutes of big walking. We're having big arm swing, big footsteps.
I'm sorry, but I'm getting a vision of that Monty Python episode. You remember that at all, the silly walk?
No.
Monty Python. Oh, I digress. Yeah, it was intentionally, it was called the silly walk episode. And everything was completely exaggerated in there.
It is exaggerated, but it helps them to be able to walk bigger. And then you have a hierarchy activity at the end where, say if they know that it's difficult for them to cook a meal, you would break it down into smaller steps. Well, today we're going to work on, taking things, using big movements out of the cupboard.
Do you have a simulated kitchen?
We do have a kitchen in our clinic, that we can use. And but whatever it is, if it's getting in and out of the car, maybe we practice sitting down to the mat and bringing your legs over something to simulate that. So we try to simulate daily activities that are difficult for them and getting them to use their big movements throughout their whole day. That's your goal.
Okay. And what sort of age groups do you commonly deal with? A real mix, probably?
With Parkinson's disease, it's throughout. You can be diagnosed younger. Some people are diagnosed younger. Some people are older. It's the whole age spectrum.
Okay. And it's primarily Parkinson's disease that you deal with?
That we're working with this LSVT program.
Okay.
The LSVT big.
Okay. What about other neurological disorders? Like we were talking with Helene, she was talking about stroke patients and other people
You
like
can
that?
apply these exercises to people that maybe have had another type of neurological, maybe they had a stroke or something. But the LSVT program, the LSVT Big, is geared specifically towards Parkinson's. So you can use these exercises, but you wouldn't really say that you're doing LSVT. You were just saying that you're using large amplitude, repetitive movement exercises if you were doing it with someone with just had a stroke or something like that.
That's fascinating. Can you tell, just for my benefit and plus maybe viewers too, just a layman's explanation of what Parkinson's is, just from your understanding of it?
Well, people are diagnosed usually when they notice they have maybe a little bit of a tremor, maybe their movements are getting smaller, they're shuffling their feet when they're walking. Usually as the disease progresses, they might notice that they have a difficult time initiating a movement. So usually that's what sends them to the doctor, is that they notice that their movements are getting small. A lot of people notice their handwriting is getting very small. So it's little triggers that this is not like it used to be.
Something's wrong or something's different.
And then they would see like a neurologist would diagnose them.
Okay. And physiologically, what's going on that causes that? Can you?
Isn't it a chemical?
It's
chemical exchange.
The dopamine in the brain, yes.
Yes.
And so that's what the medications
So the things aren't
help.
firing right in the
Correct.
brain?
It's been a while since I've looked at that, but
Yeah.
I kind of remember
I don't mean to
the
put
picture.
you on the spot.
Oh, no. I
Yeah.
kind of remember the picture from pathophysiology about that.
So the
About the
medications
receptors.
help with that, and then the exercise is a form of medication for people with Parkinson's. So these are exercises that they are going to continue doing throughout their whole life. So they're going to do them every day for the rest of their life.
At their own home. This is their
Right.
own follow-up.
Right.
Okay.
To help maintain their independence and maintain that balance with walking.
Okay. Now, what about perhaps potential for falls? I would assume if they've got this and they're not dealing with like this sort of therapy, their potential for falls could be greatly increased.
Absolutely.
And that could create fears. I'm assuming too, because most people, as we age, I say that because I'm aging myself, although who isn't?
Right.
But the fear of falling. I know my mom had fallen several times, and it was
Yes.
always a bad situation for her, and it created more and more fear that made her more fragile, almost in her own
Absolutely.
emotions and actions. So she was more predisposed.
Yes.
So do you help prevent falls by building their self-esteem or their?
Well, by doing these exercises, it's going to help them to move differently, so that will help to decrease their fall risk. And if somebody comes to therapy that maybe they're farther along in their Parkinson's diagnosis, where they're using an assistive device, a cane or a walker or something, we can adapt it by using a chair to help with their exercise for some stability. So it's
Okay. Common household things around that might be able to assist them?
just to help for stability while they're doing their exercises.
Yeah, and the gentleman that I observed, in the beginning, there was that little bit of guarding that Colleen had to do, to get behind him, because you do those rotations that can throw you
She
off
was spotting
balance.
him, you
She
mean?
was spotting him,
Okay,
guarding him, as he was doing it.
right.
And then I didn't go all the way to the end because I went on vacation, but did you have to at the end?
No, not with him. He was doing
cool.
better by the end, and he felt his balance was improving with those rotations. And
Okay. Now, you would need to have your basic training for this in general, and then you go on to more advanced coursework for this, I'm assuming, right?
so you have to either be a physical or occupational therapist, and then this is a certification program that I attended
Through the Lee Silverman
through the
Therapy
LSVT.
Institute or whatever it is?
Yes.
Okay. And that was a patient your colleague was sharing with me. Usually
Yes.
things are named after doctors that
Right.
think of things, so it's interesting. Although Lou Gehrig's disease is named after him.
Oh, true.
But still, yeah. Now, do you work with families too, like the families of patients, and help them?
Yes, usually there's a spouse or family member that comes in, and I encourage them to do the exercises with them, because everybody can exercise every day. That's only
Right.
going to be beneficial.
Right.
And so they might learn the exercises so they can be able to tell the person what they should be doing. Should they be moving, bigger, bigger
Or observing that
hand,
the movements are shrinking.
so
Yeah.
they can tell the patient if they're not moving correctly. They might be able to even demonstrate, and if they're doing them together. Usually we face each other so that they can see what you're asking
Do you
them
have
to
mirrors
do.
all in the room too for them to see
No,
themselves?
they just
Okay.
will face you, and then I would usually give them the verbal feedback. Raise your arm higher, big arm, or I might actually physically, extend their leg out if they are not bringing their leg out enough with the exercise.
Okay. Do you work on range of motion at all?
The exercises do use a big range of motion, so
Okay.
they are really like bringing their arms way out or reaching up real high, and so
Okay.
they are working on their range of motion and really their whole body with these exercises.
Okay. I'm a real big one on range of motion because of yoga. 'Cause
Right.
really, that's quality of life is what I
Yes.
call I call it range of magic.
Yeah, oh, that's
Yeah,
That's
because
good.
it keeps people moving.
Right.
And when you slow down and you don't move as much anymore, it's like a good old car, it's going to rust,
Right.
So it's important to keep things happening like that. And stretching too. Do you do stretches at all?
Not with this program, not with the
Okay.
LSBT big. It's not really stretching. It's more increased amplitude, repetitive exercises that we
Okay.
have them do.
And are they probably involved with other complementary therapies, for instance, like the aquatic? Or do they intermix some of these therapies?
No, by the time they're done, they might decide that along with these exercises, they're feeling well enough that maybe they're going to join a gym or they're going to start swimming or
Or a walking
add
program
some.
maybe or something?
Walking program is part of what their home exercise
Good.
program is when they're done. Yes.
Okay.
So usually we try to encourage doing some type of other physical activity along with these exercises. Like the person that I recently discharged, she's back to golfing.
Oh,
So,
okay.
and really enjoying it.
And that's the quality of life right there.
Right.
Yes.
Yeah, and self-esteem too.
Right.
Because plus too, if she loved golfing and felt she couldn't, that could increase potential for depression too. Throw
Oh,
in a 6-month-long
absolutely.
winter.
Right.
And
cold at that.
Right. Yeah. So we've been speaking with Debbie Clark. She's a physician liaison for physical medicine and rehab at Botsford. And then
Yes.
we've also got Colleen O'Connell Fix, who's right here. So I appreciate your time very much.
thank
you
you
for
for
coming.
Thank
inviting
you. We
us.
appreciate you having us.
Cool. All right. Thank you very much for watching.